My name is Mirav. I am a physical therapist. I've been doing pediatric PT for, I don't know, maybe 30 years, I would say. I met Judy Carmick back in 2019. One of my kiddos was like, I want to do eSTEM. Do you know anything about it? I was like, not really. She said, well, can we bring Judy Carmick here to Dynamic Solutions to treat my kiddo? So Judy came to Dynamic Solutions, and I kind of hung out with her all weekend and took her to lunch, and I was just in awe of her brilliance. And then after she left, I said to her, Judy, I think you need help teaching. And I don't think enough people know about TASES. People know, but not enough. And it's not being used as widespread as it should. And I was like, I'm afraid that this work isn't going to live on. Please let me help you. So I trained with Judy for almost 5 years. My mission is to really establish it as a very concrete method with guidelines on how to use it and how to apply it, and to document our data and to make sure that everyone's got the access to the knowledge so that the work can keep progressing. So let's start off by talking about the different types of eSTEM, because there's so much confusion and there's so many choices out there. And let's like really focus on what is TASES here in this class, right? And why TASES versus some of the others. What is the difference between TASES and FES, functional electric stimulation? FES is, for example, if you have a person that is in a crouched gait and you decide, well, he's not extending his knees, so what's the muscle that I should go to? If someone's not able to extend their knees, what muscle would you go to? Quads, right? That's FES. And then you do your squats, you do whatever it is to work on terminal extension in a functional way, right? TASES is different than that. TASES is task-specific electric stimulation. It is always active. We are not doing anything passive ever. It is always associated with motor learning, sensory input, and movement. With our kiddos, we're really looking at what is needed to accomplish the movement pattern. Where is the lack of motor control, right? Mid-range control. So you have to kind of shift your thinking in that way. The work with TASES originally started with children with cerebral palsy, works really great with children with hypotonia, works great with children with idiopathic toe walking, works really great with genetic conditions. When I was a young therapist, a lot of our children that had these genetic conditions were really just classified as cerebral palsy, right? Now we know better. We know more. There's better genetic testing, and our kiddos are getting more specific diagnoses. So these genetic conditions respond really well to TASES and electric stimulation. We do great work with scoliosis, and we also work with children with arthrogryposis, because you can improve range of motion with TASES, right? And you can improve the movement pattern with TASES because you're doing it in a very task-specific way. We're using a lot of active assisted range of motion, right? Okay, what are the 5 key principles that we need to keep in mind for TASES? Evaluation. All right, we're going to go through. What do you need to evaluate? How do you know which kid to use it with, which kid not to use with? What do I need to look at to make sure that I'm making changes the way I need to be making? Muscle choice. How do you know which muscle to use? There's so many options. Where do you start? Like, these kids need so much change. How do you start? How do you know which muscle to use? And again, we're not going to just go lower quarter, one electrode here, one electrode down there. We're going to be very specific and intentional with our choices. Parameters. Use all the different parameters, set it very easily, understand what the different little nuances of the unit are. Very important to realize that all our work being done with TASES needs to be very task specific. It needs to be gait. If you're working on gait, you're going to work on gait. If you're working on sit to stand, you're going to do it during sit to stand. If you're working on getting up from the floor through half kneel, you're going to work on half kneel. It's all very task specific. Weight shift, one-legged balance, all those things that are needed are going to be in here. And we're also going to talk a little bit about orthotics, because a lot of the thinking that has been going on up until now has really focused on a lot of immobilization, inhibition of the spastic muscle. And we really need to have freedom of movement to use TASES effectively. So it's very difficult, pretty much impossible, to use TASES really well on the calf if you're in a solid FO. We're not using solid AFOs during TASES. Okay, we need free second and third rockers. That tends to be a little bit controversial. However, some of the work that's out there that really emphasizes solid AFOs and really aligning the tibia, it's not that I disagree with it. I still agree with it. But I have electricity. So I don't need all that control 100% of time during my therapy. I'm trying to gain that control through the motor learning, and I need movement in order to do that. And I need a strengthening component in order to do that. The calf muscles of children with neuromotor and neuromuscular disease are weak. And if we keep putting them in solid AFOs, they're very difficult to move past that. Okay, digest that. I know it's a big one, but I feel pretty strongly about it. It's true. When you're using and when you have the ability to use electricity, you can let that second rocker be free and work on the alignment of the tibia in a more active way, right? My intervention is not the orthotic. My intervention is the electricity. Okay. Evaluation. You're going to look at current function. You're going to look at alignment. Alignment is key. Alignment matters. When you look at a child and the alignment is faulty, that is kind of where you're going to start. Now, are you going to start there whether the child is working on sitting balance, trunk control, head control, or you're going to start there whether the child is working on standing, whether the child is 8 years old and already is walking and running around? You're still going to take a step back and look at alignment. And that's what we do as therapists, right? That's like our specialty, right? So let's make sure that we really focus on that first. Spasticity management is not driving my therapy. Alignment and function are. One of the things that is really heavy right now in the literature is the outcomes are improved when the child and the family set the goals. If you have a child that can talk to you and can express, ask them, what do you want to do? What do you want to be able to do? Why are you here? Why do you want me to use TASES? Why are you, because at this point, I'm getting a lot of kids that come to Dynamic Solutions and they're coming for therapy that wants to focus on electric stim, right? It's really important to talk to the parents and the kids about that. Establish your PT diagnosis. Now, I know that OTs aren't doing that as much, but you can still establish OT problems, right? What is the actual thing that's going on? Is it decreased range of motion? Is it decreased strength? Is it poor motor control? Is it decreased sensory stuff? Like, what is actually happening and what is going to be your focus? What is driving this kid's movement patterns that you want to change? I always tell my newer therapists and students, pick 3 problems, because sometimes when you look at these kids, you're like, oh my goodness, there's like 10 things I want to work on, right? Pick 3. So it could be like improve alignment and posture, improve transfers or transitions, some sort of functional reach and grasp, self-feeding, self-help. Pick 3 that are really important to the family, to you, that you think are going to be your focus, and really kind of focus on that. Then you'll be able to come up with your TASES plan and your rationale and establish your potential for this kiddo.